Hello, everyone. Hi, people who are just joining, and welcome to our live virtual panel on achieving payer FQHC partnership success in the value-based environment. We're so glad you're here. Thank you for spending an upcoming hour with us. We are just going to wait a minute or two for people to come in before we get started. If you're just joining us, thank you for spending an hour with us on our virtual panel. We're so glad you're here. We're going to be talking about what successful payer FQHC partnerships look like in the value-based environment. And we're going to get started in just a minute. Welcome, people who are just joining. Once again, thank you for being here. We are talking about achieving payer FQHC partnership success in the value-based environment today. We're just waiting a minute or two to get started while people roll in, and then we will kick off. And if you are just joining, please remember that this is a discussion. We are taking your questions. So please say hello and introduce yourself in the chat. You can reach the chat by bringing your mouse down to the bottom of your screen and clicking chat. And if you have questions for us over the course of this discussion, please click Q&A and submit your questions. We're going to try to get to as many of them as we can. All right, we're going to get started. So one last time, this is our virtual panel on achieving payer FQHC partnership success in the value-based environment. We are so happy to have you here over the next hour. Please remember, this is a discussion with you. We are taking your questions. So if you have any, please submit them in the Q&A tool and introduce yourself in the chat. I am going to pass it over to our facilitator now, Carmelo Cruz Reyes. He is the Chief Managed Care Officer and co-founder at Yuvo Health. Yuvo Health provides administrative and managed care contracting services to FQHCs. Carmelo's career spans 20 years managing health and human services initiatives at organizations like Public Health Solutions, Healthify, and Emblem Health, where he led value-based contracting efforts for New York State's FQHCs. Dedicated to serving the most vulnerable and disenfranchised, Carmelo has served as a mayoral appointee to the HIV Health and Human Services Planning Council of New York, a consultant at La Nueva Esperanza, which provides community-based services to Brooklynites living with HIV and AIDS, and as a board member for the Ryan Chelsea Clinton Community Health Center. I am now going to pass it off to Carmelo.
Thank you, Adrian. I appreciate the kind introduction. And thank you all for joining us today to discuss just how payers and federally qualified health centers can go about achieving success in the value-based environment. As Adrian shared, I am co-founder and Chief Managed Care Officer here at Yuvo Health. A bit about Yuvo Health. Yuvo Health is an IPA MSO dedicated to bridging the value-based contracting as well as the administrative gaps that exist between payers and federally qualified health centers in the value-based contracting space, essentially strengthening those relationships. It is my absolute pleasure to introduce you all today to our esteemed group of panelists who you see before you, who all represent individuals from the payer, the FQHC, as well as the health policy space. So without further ado, I look forward to delving into the introductions of our panelists. And do please forgive me, I will be reading off the bios for each of our panelists, so you may get a bit of forehead action as I go through each panelist. So we're going to start off with Natalie Lukashevitz, Vice President, Network Development and Contracting at Buckeye Health Plan in Ohio. And Natalie has more than 30 years of network management experience in both the health plan and health system arena, having served as key leader in developing and executing network growth and financial strategy at several successful health plans. Before joining Buckeye, she was vice president of network performance at Priority Health Plan in Michigan. She studied health services management at University of Central Florida and executive management and leadership at Case Western Reserve University. Next, from the payer space, we have Panteli Konakapis, Vice President, Value-Based Payment Initiative and Risk Adjustment, Fidelis Care in New York. With a healthcare career spanning 20 years, Panteli Konakapis, better known as PK, spent the first decade on the plan side, joined the provider side at the Hospital for Special Surgeries Managed Care Contracting Department, and then returned to the plan side with Fidelis's value-based payment team. While at Fidelis, he has overseen the negotiation of hundreds of value-based payment contracts, including the value-based payment contract that exists between Yuvo Health and Fidelis Care. So thank you, PK. And more recently has also assumed responsibilities for risk adjustment, as well as the organization's social determinant of health strategy. From the FQHC space, we have Dr. Ari Benjamin, Chief Medical Officer from Joseph P. Adabo Family Health Center in New York. Born into a hardworking family that has always given back to their community, Dr. Benjamin eagerly went to medical school to fulfill his life's dream, to make a difference by serving the community in which he grew up, Rockdale Village in Jamaica, Queens. As Chief Medical Officer at Adabo, he enjoys the balance of patient care and having a meaningful voice in important decision-making. Dr. Benjamin earned a Bachelor of Science at the City College of New York, as well as an MD from Ross University School of Medicine, and is trained in internal medicine. Also from the FQHC space, we have Jean Polster, retired president and CEO, Neighborhood Family Practice in Ohio. Jean Polster is an RN, recently retired as president and CEO of Neighborhood Family Practice, a federally qualified health center with health centers throughout Cleveland, Ohio, offering primary medical care, behavioral health, dental, midwifery, and pharmacy services. Passionate about eliminating health disparities, she has served various leadership roles in hospitals and social services organizations, as well as on boards of several nonprofits. Jean holds a Bachelor of Science in Nursing from University of North Carolina at Chapel Hill and a Master of Science in Health Policy and Management from Harvard School of Public Health. And last but not least, from the health policy space, we have Jonathan Palisak, health economist from the University of Michigan. Jonathan is a PhD student in health policy and economics at University of Michigan, and also holds a master's in public policy from Berkeley and a BS in economics from California Polytech State University. Determined to impact social and health spaces, he's passionate about advocating for underrepresented populations. Jonathan's previous consulting positions include California Medicaid, Kaiser Permanente, University of California, Berkeley, California Select Committee on Health Reform and Public Hospitals, and the Center for Medicare and Medicaid Innovation. Most recently, he worked at the Department of Health and Human Services as their primary Medicaid financing analyst, and currently sits on the Society of Health Policy Young Professionals Executive Board. So thank you all for joining us today to discuss this important topic around how payers and federally qualified health centers can bridge the gaps that exist in the value-based environment. So we are going to spend the next 30 minutes delving into a few questions that we have for our panelists. And we're actually going to start off with a question directed to our panelists from the payer space. So PK and Natalie, ready to go? Okay, so the question for you two is, what are Fidelis Care and Buckeye Health Plan doing now that you believe is successful in the FQHC payer value-based payment space? And what would you like to do more of? So PK, we'll start off with you.
Sure. Thanks, Carmelo. Quick story. I remember back April 2nd, 2019. It was late in the evening, around 6 o'clock. I was on the phone with New York State because we had just recently, right before the end of our fiscal year, had submitted a contract, a risk contract for an FQHC. And we were discussing with the Department of Health how that contract was going to be rejected because of the inclusion of downside risk. Because in New York State, we cannot take, or FQHCs cannot assume the financial risk in a VBP arrangement. And I think that limits an FQHC's ability to innovate under VBP, really have the motivation to explore different types of VBP arrangements, different types of programs. And it also prevents them from achieving a higher percentage of shared savings. So since that date, moving forward, fast forward to today, 2022, with organizations like Yuvo and other IPAs of FQHCs, or with FQHCs figuring out a way to partner with larger provider organizations, hospital systems, whatever the arrangement is, out of the 77 FQHCs that we're contracted with, 30 of them are actually part of a risk arrangement. So we're beginning to grow that book of business. FQHCs are becoming a little bit more sophisticated in their consumption of data analytics. But I think the most important thing, and what I'd like to do more of, especially with the new waiver on the horizon in New York State, is to further explore FQHC's ability to truly impact health equity in our delivery system. I think they are better positioned with relationships with community-based organizations, with the membership, the patient population in their communities, to really get individuals into the social, align individuals with the social care organizations that can address all of the things outside of the health system that impact their health outcomes and their quality of care. So we're continuing to build that. I think there's a lot more of that on our horizon, especially with potential funding from CMS. And I'm looking forward to what's next with advanced VBPs and advanced VBP models in FQHCs.
Wonderful. Thank you so much. And yes, federally qualified health centers are actually very well strategically placed in the community to impact on the positive areas of addressing social determinants of health. So glad to hear that Fidelis is also prioritizing that. Natalie, what's happening on the Buckeye Health Plan side with your engagement with federally qualified health centers?
Sure. So thank you, Carmelo. And, as PK said, I think that the FQHCs are very well positioned to have a significant impact in improving the health of the lives that we serve. I think Ohio tends to be a little bit more conservative. And we are, when you look at managed care, there's usually a bell curve. We tend to be on the left side of it, creeping up to the top of that bell rather than on the downside. So we've actually been engaged with our FQHC Association, who has a messenger model arrangement with 65 FQs in the state of Ohio. And we have partnered with them over the past 5 years to put into place really a shared savings arrangement that has a quality gateway. We have built a lot of opportunity to raise funds to support various activities or needs that the FQs have identified. So during the height of the pandemic, we worked with them to get PHE over to them, making sure that they had everything that they needed to continue to see patients. We've also worked with them to obtain grant money so that they could really focus in on some of their diabetic patients by getting them a diabetic retinal scan machine. So, again, we're really trying to identify what are the needs that they have, how do we support them so they can be successful in these types of arrangements. I think that, one of the things the past few years have really demonstrated is that, the labor shortage that we continue to face definitely impacted our healthcare providers, particularly in the FQ space. We saw a significant amount of staff turnover. So, the continuity was somewhat lacking in understanding the program, understanding some of the goals of the program. We actually have employed a full-time individual who used to manage an FQHC, and her only focus is to work with the FQs, really to bring them down that path of managed care. So anyways, it's been a journey, and I think that hopefully we're coming out of the whole pandemic space. I know that our FQs year over year have continued to improve in the bonuses that they're receiving. Sometimes I think that they are challenged when the metrics change. And then of course their scores aren't improving year over year in those particular metrics. And so that can be frustrating. So I think that it's beholden on us to identify what are other opportunities within these managed care arrangements to offer them the space to earn additional funds in the face of metrics changing, et cetera.
That's wonderful. And thank you for also highlighting how difficult the past 2 years have been, not only for payers, but also for the federally qualified health centers being on the front line of the COVID-19 pandemic and having clinicians and administrative staff be exposed to that and have that COVID-19 fatigue. And I think that that's a phenomenal segue into our next question, which is directed at our FQHC panelists, Dr. Benjamin and Jean Polster. So the question for you two, similarly, is what challenges have you experienced in the value-based payment space, and what changes do you think need to occur in your partnership with payers to achieve success in a value-based arrangement? And why don't we start off with Jean?
Thanks, Carmelo. It's great to be here. Just a bit of background. So my health center had seven locations serving 22,000 individuals. 1 out of every 5 of those individuals speaks a primary language other than English. And there's certainly, as in every FQHC, a ton of folks who are vulnerable and living in poverty. And I think that when I think about the opportunity for value-based pay arrangements, I think that I'd love to see the payers really understand kind of the fact that the care management models that we've deployed for our patients in the past just really haven't worked for the patients. That I think there could be a much stronger partnership between the plans and the FQHCs so that we could have the care management resources that we would need so that we could really achieve some of the better outcomes. They think that health plans and FQHCs have been living in in sort of some siloed universes where the language hasn't helped us, the language and the data. So let me just talk a little bit about that. So there's 57 health centers in Ohio, and a number of them are quite small, 10,000 patients or less. In those organizations, and my organization used to be small like that too, you really lack the resources to build the care management and data systems that you need. And so I was an early pioneer in value-based care, like 15 years ago. Because I'd spent time as a hospital administrator in California, and I'm like, let's go, value-based pay, and have run into issues that have really continued through the whole 15 years. One is that health centers lack the resources to be able to build the systems of care and care management that would really, as I mentioned, that would really help. I think as health plans and FQHCs, we need to recognize that we have the same goals. We want to achieve the triple aim. The health plans want their customers to be satisfied. We want our patients to be satisfied. Those are the same people. We want to get high quality healthcare outcomes, and we want to have lower cost and utilization of, particularly of less necessary services like overutilization of the ER and ambulatory sensitive hospitalization. So how do health centers get there? They've got to have the resources to be able to look at the data and see that. So, But health plans are often very reluctant to give money up front to build some of those infrastructure systems. So it seems like there's kind of this ping pong where it's like, well, if you did better, we'd give you money. And we say, if you give me money, we'd do better. And so I think that really having a good understanding of what would it take, and could some of the care management be delegated? I know there's lots of rules about that, but I think those are some of the things that I could see really being improved. I think developing a shared language as well. You know, throughout, we have issues with patient attribution, and we also have issues with plans looking at the billing and claims, and the health centers looking at EHR. So if you don't upcode your, well, upcode's a bad word, but if you don't code appropriately,
We don't use that word, Jean.
No, never upcode. But the point I'm making here is that health centers under our prospective payment rates never had any incentive to code. And as a CEO, the last thing in the world I wanted to do is tell my docs and nurse practitioners that they need to spend a lot more time coding. You know, with Medicaid, you know, the plans pay first in Ohio, and then we get a secondary payment from the state. That's how we've been paid under the PPS model as a health center for years and years and years. And then you say, well, under an ACO model or under a value-based model, you've got to code for all this stuff. You got to make sure that you put in there that you did that blood pressure and what the blood pressure was, you know, if it was high or low, and all of these things that add additional burden on the health centers. Whereas if plans were able to look at the EHR data, and they would be able to see, you know, a more true picture. But we're not measured on the EHR data. We're measured on the billing and claims. And actually, you know, just true confessions, during COVID, I told my folks, we're not even going to pay attention to diagnosis confirmation. We're not going to pay attention to any of this because we were trying to get shots in arms. So, you know, now we're at a point coming out of COVID where FQHCs are exhausted, but there is so much opportunity for health plans to rely on FQHCs to better serve their patients, and to have really meaningful data capture so that we're looking at the same data together, we're looking at the same patient lists together, and then we can see, okay, how can we improve the health plan in their achievement of quality outcomes, and at the same time the patients are getting healthier. And so I have a great belief that that can happen as long as we start to have a shared language and understand the constraints that we're both under as kind of separate industries.
Thank you for those insights and for the real life examples. I definitely hope that we have an opportunity, and we will, to circle back to some of what you surfaced, and would love to pass the baton over to Dr. Benjamin to speak about his experience at Joseph P. Adabo, which may be similar to the experience that you had in Ohio with your FQHC. So Dr. Benjamin?
Thank you, Carmelo. And yes, I do. A lot of the challenges I face are very similar to what Jean mentioned. Just a little bit about Adabo. We are a 5-center FQHC located in New York City. We have 2 locations in Far Rockaway, Queens, 2 locations in Jamaica part of Queens, and in 1 location in the Red Hook section of Brooklyn. All medically underserved areas, and we have a lot of the same socioeconomic challenges that Jean mentioned as well. I remember, first getting into discussing value-based when I was a provider working at another FQ, and getting these reports from my nurse manager at the time saying, "Oh, you need to make sure you're coding this or you're not doing that." And I remember kind of being annoyed by it, and all this work that I'm doing, and now you're telling you want to add on additional work and say that we need to do this and that in order for us to get paid. So that is a challenge from the provider level, and just trying to change up, especially on more seasoned providers and getting them to buy in on this changing workflows. Other challenges, as you mentioned, is about the data, data integrity, working with your MCO partners to make sure that, just the accuracy of just the rosters. A lot of times you have patients attributed to you who you've never seen, but you're held accountable if this mystery person hasn't had a colonoscopy. So working with provider and working with the partners on improving that data, and then also on quality metrics, especially on services that are provided outside of the health center that you are somehow responsible for ensuring get done. That is a huge challenge. Also, resources, as you mentioned, resources are very, very difficult. Getting a QI staff who is responsible for monitoring this data, presenting this data, gathering the data is always difficult. And then that's also related to my last challenge, which is executive buy-in, buy-in from upper management. A lot of times, you're asking for a QI coordinator or an extra nurse to meet some metrics, and the ROI on that may not be as immediately apparent. And your CEO, your CFO say, why do you need an extra nurse, or why do you need an extra staff member for that? So I think it's definitely improving and it's evolving. Data management, there are a lot of new solutions since I first started on improving that. So I'm optimistic that it will change, but it is a growing curve.
Thank you so much for also sharing your experience and surfacing some of the challenges that Joseph Dabo has faced and continues to face, and not only addressing some of the experience that you've had with coordinating and partnering with payers, but also surfacing the real experience of the internal flux that exists within the federally qualified health center space. So thank you, everyone, for sharing your insights and your perspectives. I'd love to open the floor because I feel like a lot of information has been shared, and there are some great morsels of information here to chew on. So I'd love to open up the virtual floor to all the panelists to discuss what has been surfaced in response to the first two questions, and also give Jonathan an opportunity to address the responses from the health policy perspective as well. So I'm going to open up, and we'll start off with Natalie and PK. What are your thoughts about what has been shared so far?
I'll jump in first. Go ahead, Natalie.
I was just going to say, I'll jump in here. I hear the challenge that both Jean and Dr. Benjamin have mentioned around resourcing, as well as, is there opportunities for funding, right? So that they can, either get updated EMR or get the data resources that they need in order to better manage the population. And I think that's where, health plans have to be a little bit more creative. It can't just be, here's a shared savings. If you have savings, you earn money, and gosh, good luck, go at it. We hope you're successful. When we entered into our arrangement 5 years ago, we had been trying for many years, right, to work with our FQs and say, gosh, could you, close these gaps in cares, and everybody's sitting there going, we don't have the resources to do all of this. And so, one of the things that we did was look at how can we put some funding in the arrangement for, the FQs to take advantage of to, upgrade their EMR or whatever it was that they needed, so that they could, right, manage their data more effectively, and track their patients and the needs of their patients more effectively. And that's worked really well for us. And I think that the FQs that we're partnering with on this particular program, certainly have come a long way, from year one into year 5. And again, I think that that's where the health plans have to step up and be more creative in how they approach some of these arrangements.
Thank you, Natalie. PK, thoughts?
General PSA, if I may, to my FQHC partners, whom I value very much, but coding is absolutely critical. Coding is critical because Medicaid is so highly regulated in New York, and I'm sure in every single state. And because Medicaid is a fixed sum of money that is just distributed amongst plans based on acuity, coding is critical. So the more accurate the coding, the more reflective the revenue to the plan will be based on the population that we have as membership or the patient population that you are serving clinically. And then the creativity, piggybacking off on Natalie's comments, creativity could lie in how we concurrently risk adjust in VBP models, because that takes the acuity of your population in real time into consideration. So that coding is not, yes, from our perspective, from a revenue perspective, that coding is realized 2 years down the line in New York, but we make it a more real-time impact with the methodology we have in our arrangements, so that you can essentially reallocate revenue away from lower acuity populations to higher acuity populations, and that shows your performance more efficiently, more accurately, and that can drive revenue more, earlier in the relationship. So coding is critical.
Great.
And if EMRs were submitting data to the state that allowed them to set their Medicaid budget, then maybe it'll be a much simpler world, but we do have to translate it to a standardized format.
Agreed, absolutely. And as you all know, Yuvo is aligned in that belief. That's why we have a head of risk adjustment that focuses just on that, to ensure that we're serving both our FQHCs and also the payers in the way that needs to be served. I'd love to hear from Jonathan about what we're hearing from the health policy space about the importance of payer and federally qualified health center partnerships.
Yeah, would love to speak on that. Just from the literature and from interviews that have kind of gone out, it's incredibly important for the payer and FQ relationship to be really strong. I think in the examples that we have seen that have not worked out, it's often been to kind of breakdowns in communication in a number of different avenues. So I think the successes that we've seen, there's really robust data sharing arrangements between the two entities. And really clear communication for things like attribution. I think attribution has always kind of been something that has historically been a problem where, and again, there's some fault that lies on policy officials as well when we kind of look at those, but a lot of times there hasn't been clear communication between kind of guidelines as to how attribution works. And that's a really important part, I think, of plans and providers working together well. I also think that just when we're thinking about success between FQs and plans, it goes to what the other panelists have spoken about in terms of kind of upfront investment. And that's something that I think the state and the federal government can play a lot larger part in helping with that, just because, again, when plans submit things for, in terms of just kind of like their encounter data, a lot of times when they pay FQs and providers for these upfront investment type things, those aren't really things that get included in their rate building process, in the next year or two. And so there's stuff like in lieu of services or value added services or other state policies that have been implemented that are trying to encourage plans to be able to pay for those upfront investments and get them to get reimbursed in future rates as well, just because, again, it's more helpful when everyone's getting paid for the work that they're doing. But yeah, I really think that there's just a bunch of different things that policy officials are looking at, but they've always said that plan and FQ relationships are very important for the success of any of these programs.
That's great. That's phenomenal. And I'd love to give Jean and Ari, Dr. Benjamin, a minute to respond to the discussion here as well, to jump in. Any thoughts, comments, Jean or Dr. Benjamin?
Well, I'll just say that I would agree with a lot that's been said, and I think there are opportunities, for the health plans. I think one of the things that I'm just reflecting on is how do the relationships get built? Because oftentimes the individual in the health plan that's tasked with meeting with the FQHCs is not the one that's necessarily, they're not necessarily empowered to problem solve around some of the things that we've talked about. And so, how can those conversations occur? I very appropriately, PK, you talked about coding. We were working with some plans that they come in and help with the diagnosis confirmation and things like that. So how, where can the plans and the health centers identify best practices where a health plan can say, wow, this is what we did in, Iowa, and we had this great success. And so because so many of the health plans that we're working with have a national presence. And so, that how can, even though our Medicaid platforms are so different from, just the differences between Ohio and New York are very stark. But, how can there be a sort of an elevated conversation about best practices of health plans and FQHCs working together that can be scaled? Because we certainly have very successful networks of FQHCs that have worked this stuff out. But then you've got a ton of small FQHCs that really want to be invited to the party. And so how does that come along?
Yep. We want everybody to be able to have a ticket to the party and a seat at the table for sure.
Yeah.
Dr.
And
Benjamin?
while I'm unmuted, I just wanted to apologize that I have a family issue that I'm going to have to leave the call a bit early, but it's been great to participate.
No, thank you. It's been an honor to have you on this virtual stage with us. Thank you for your participation and your time. I know you're quite busy, so we really appreciate you. Dr. Benjamin?
Yes, just to kind of follow up on better collaboration to improve, specifically with gaps in care. It seems like every meeting I have with an MCO, the question is, okay, well, what kind of outreach are you doing? What kind of calls are you making? And it's almost like we're being held accountable for it, but folks don't answer their phones. My phone has rang about 3 times since we've been on this, since we've been started. Folks don't answer their phones. So, I think both sides need to be more creative on how we're engaging with our patients to improve that. I was joking with Dr. Council the other day that we need to really start to be on folks' social media pages while they're mindlessly scrolling through Instagram or Facebook. If they can get a reminder to get their mammograms done, that's the way to do it. But yeah, we really need to address that part of it if we're going to get some better numbers for both people, both sides.
Yeah, I think we're hearing from across the board, like innovation and tapping into available resources and being creative and thinking outside the box is really what's going to bring the partnership between payers and federally qualified health centers to the next level. And just to the Dr. Council reference, Dr. Laura Council is our Chief Population Health Officer here at Yuvo Health. So she and Dr. Benjamin, I'm sure, have been trading quite a number of stories about how they can work together in order to achieve success in the value-based arrangements that we have in place. So I would love to pivot to Jonathan and really focus on the health policy space here. So the question for you, Jonathan, is what is the health policy space telling us about the current Medicaid VBP landscape, and how should we be preparing for more robust engagement between payers and federally qualified health centers in this space?
Yeah, absolutely. So much to talk about in the Medicaid VBP landscape. But a couple things that I think I would really want to hammer down on are one, we really live, in a managed care world now. As everyone knows, Medicaid lives, I think it's close to 80% of enrollees in the program are in Medicaid managed care. But when I say we live in a managed care world, I don't only mean that for enrollees, but I mean that in terms of payment flow as well. I think that what we have seen historically for a lot of providers or FQHCs is, you might get payments from your managed care plan, and obviously you'll get the wraparound of PPS from the state, but you might be getting supplemental payments from other areas. You're getting Section 330 grants, stuff like that, but providers are getting basically funds from a lot of different areas. And then obviously there's Section 1115 waivers, and a lot of times those have incentive payments or incentive programs in that, and there's extra payments coming down from that. From what I think we have seen from the past two administrations is that there's kind of been a more concerted effort to consolidate payment flow through managed care plans, especially for value-based payment. So one example is DSRIP, so Delivery System Reform Incentive payment programs. So those programs have historically, been approved by CMS, but when states have come back for the second or third iteration of them, the federal government and CMS have really been like, we want you to roll these programs into your managed care framework. And while we're very interested in still having pay for performance and quality measures and stuff like that, we want it to be part of managed care plans and kind of flow through that. And so there's things like directed payments. There's something called a 5% incentive band that's in Medicaid managed care statute that plans can basically build an additional 5% into their rates if providers hit certain quality targets and stuff like that. But what I'm basically getting at is that for any value-based payment or anything in the Medicaid space to be successful, you need to have a good relationship with your plan, because in all likelihood in the next 5 to 10 years, it's really it's going to be impossible to do so without a really good plan relationship. So I think that's really important. The other things that I would see in the space, and we've talked about it already, is just stuff like Medicaid ACOs or a lot of care coordination. So it's great to hear that there's a lot of shared savings happening between FQHCs and plans and stuff like that. But you're going to, I think, see more of these kind of large collaboratives where you have a bunch of different providers and plans and maybe community organizations where they all, again, share risk. There's some sort of total cost of care, and then there's some sort of additional payments you get for hitting quality incentives and so on and so forth. And again, that's another one of those things where FQs and plans need to have really good relationships for them to be successful. Again, with attribution, the fact that FQs see patients and have a certain patient mix that, again, you can really achieve a high amount of savings with them. And this goes again to the current administration's kind of drive towards health equity as well. Just because of the patient demographics that FQHCs see, there's a huge opportunity here for FQs to play a really large part in the health equity goals that the administration has. And there's a lot of funding that has been talked about in that area, and it's really exciting. But I guess what I'm saying is again, managed care, it plays a huge role in Medicaid, and it's going to only get bigger. There's going to be more, again, of this capitated total cost of care environment. And all of these things with a strong FQ and plan relationship, it's going to create success. I mean, again, for like the total cost of care stuff, just an example is that, maybe you as an FQ, if you're smaller, maybe you don't have necessarily like a large amount of relationships with large health systems in your area, but the plan maybe has obviously a pretty robust relationship with health systems. And if you're working in a total cost of care arrangement and you're looking to do, ED diversion, the plan can be that partner to connect you with that health system to really, strengthen the relationship with the health plans and really help you with, these kind of diversions of unnecessary high cost visits. And so it's, again, the relationship's important. I think that's really the secret sauce to success in Medicaid VBP, and it's exciting to see that Yuvo's playing a large part in that. And it's great.
Thank you, and thank you for surfacing all of that. I'd love to keep our finger on the pulse of health equity and care coordination, and open up the floor to PK and Natalie to discuss what are you all focused on. I know PK and I have had a number of conversations around your focus on the social determinants of health and the work that you're doing in the health equity space. And Natalie and I have spoke about that as well. Could you share a bit more about the focus there and how that ties into the work that you're doing with federally qualified health centers, or the work that you would like to do more of with FQHCs?
Sure. I always had this belief that there's a trinity of sorts where it's plan, provider, member / patient, and no single component of that trinity could do it by themselves. Patient can't navigate a complicated health system by themselves. Although we're connected to the community, we're connected to our providers, we're connected to our members, I'm not going to sit here and tell any of my FQHC partners that I am more connected to the patients that they're serving than they are. And then the FQHCs, from a funding perspective, the ability to have a greater amount of supplemental revenue through quality programs, through VBP, that only enhances their ability to do the work that they do. Of late, I've added a fourth component to that Trinity. So it's a square, which sounds not as fancy as Trinity, but that square is social care organizations, community-based organizations. I think they have an equally important role in this picture. I've often internally, when describing social data, which we do not have a good pipeline for. We have gigs and gigs and gigs of data, and it's all clinical. And I've internally described that as the tip of the iceberg. All of the ice underneath the surface is the social data that drives an individual to make the decisions they make on a daily basis that has such a huge impact on their health outcomes, on their quality of life, on how they view our delivery system, on whether or not they feel comfortable with a physician because he or she may or may not look like them, may not speak like them, may not understand them. Our highest quality organizations consistently
I think we may have lost PK. Did we?
I think we might have lost him. I also.
Yeah.
Mhm.
I think he may have fallen off.
And what he was saying was just so good. The webinar couldn't even.
It was very engaging.
was
Yes.
no
And stay
bandwidth.
tuned. Stay tuned for
he's
next
back.
time to hear
Oh,
the
you're
rest.
back. We lost you, PK.
We lost you. We said that what you were saying was so good. The webinar crashed.
Sorry. So, well, it kept, trust me, it was still good. So not to rehash all of it and give the floor to somebody else. We all need each other is basically what I'm trying to say. And as we, Jonathan mentioned partnership, Dr. Benjamin mentioned partnership, it's critical. And if we're vocal with one another, and if we're having a conversation around attribution, if we're having a conversation around data, where there's opportunity and we're working together, that's how we achieve the outcomes.
Absolutely. Absolutely agree. I think that we can all agree to that here. I do want to give our
I'm
audience.
signing off. It was
Thank you,
great to see
Jean.
everyone. Have a
Good
good
to
day.
see you too. Thank you again for participating. Appreciate you. I do want to give our audience members an opportunity to surface questions that they have for you all as well. So the next 8 minutes or so, we're going to dedicate to questions that have been pulled from those that are participating. So Adrian, do we have some questions?
Yes, let me pull one up. So here's a question that someone submitted. Patient engagement with the healthcare system, specifically with their PCP, is traditionally very low within FQHCs. How do both the FQ and MCOs on the panel address this in workflows or VBC deals?
Great. Would you all like to have the question repeated, or would somebody like to take a bite at it?
Well, I can definitely start at least. So, engaging patients so that they're seeing their primary care physician at least once annually, right, is a huge focus for our organization. And I'm sure it is for many. And so a couple of things that are changing in the Ohio landscape is that we are implementing something called care guides. And these are individuals who will provide some of that care coordination support that care management doesn't really address, right? Care management is for, that upper, tier of members who have serious and chronic conditions, that have, multiple acute issues, et cetera. But what do we do with the rest of that population, and how do we engage them? And so the care guides role will be to not only try to engage them with their primary care, right, but to also assist them with some of those social determinants that may be preventing them from taking advantage of the care that is available. So transportation, food insecurity, housing. If you're worried about, am I going to, feed my kids tonight? You're not worrying about getting in to see your primary care doctor for, your wellness visit. So, this is going to be an interesting change in how Medicaid is done in Ohio. And hopefully we are going to see improved engagement primary care practice, because as I think Dr. Benjamin was saying, you guys are tapped out. You're going, I don't have people that can, sit there, call members who most often don't want to answer their phone anyways, right? And frequently what we have found is that the majority of our members prefer a text message over any kind of phone call. So we've invested in some resources that allows us to text our patients. Again, we're trying every means possible to engage with them, let them know that we're here to help eliminate some of the barriers that they see or that they're experiencing, to assist them in getting the care that they need.
Great, thank you so much, Natalie, and good to hear that there's some incredible stuff happening on the Buckeye side with respect to really trying to meet the members where they're at and addressing their needs in a timely manner. PK, anything you'd like to add?
The meeting where the members are at, I think, is an important concept. We've partnered with organizations that have mobile vans, meeting at community centers. We are a plan that is present in every single county in New York State. So the geographies, the community needs are very different from New York City versus up in the Adirondacks versus Buffalo. So understanding how those communities interact, or the people of those communities interact, addressing low utilization with primary care, not just amongst FQHCs in rural New York, is something we're very interested in. And if you think about what does creativity mean? Who are you trying to address? Who are you trying to interact with? Those that have a higher level of needs, multiple chronic conditions. Typically 50% of the population is healthy as long as they come in once a year for their annual well visit. That typically checks the only box they need to be checked. But the individuals that have multiple chronic conditions that aren't interacting with their physician as much as you would like, or a specialist as much as you would like. I looked up this stat recently, and it's a little dated. It's 2019, but only 10% of Americans have mail-ordered pharmaceuticals. Everybody else is going to the pharmacy. So that is an interaction with a licensed clinician at least 12 times a year or every 90 days, where maybe we leverage pharmacists to not deliver the care, because they're not going to supplant a primary care physician, but maybe deliver a message. Have you done this lately? Have you gotten this checkup? When was the last time you got a mammogram? Are you checking your, hemoglobin A1C if you're a diabetic? I think these are conversations that can happen because individuals are coming into town. There's generally decent medication adherence, amongst the population with chronic conditions, and it's creative thinking like that can at least increase our chances of having a meaningful conversation with the individual, with the patient, in the hopes of getting them back into the PCP's office or the specialist's office where they should be ultimately.
Yep, I think that is a phenomenal idea. We have discussed that here at Yuvo as well with respect to how can we leverage the players in the space and all the players in the space to the top of their license and the best of their ability to engage the member at every intersection of the member's journey through their healthcare space. So thank you for that. Adrian, do we have another question that we could surface?
Yes. This question is from Kirsten. Thank you, Kirsten. They ask, are the health centers on the panel working with their primary care associations to explore opportunities to work with their state to move from the per encounter FQHC PPS/APM towards capitated FQHC APMs? If so, how do you see such a model aligning with or supporting the population health VBP models you have with payers? It's a long question, so I'm happy to repeat it if that would be helpful.
And I think that question is directed right at Dr. Benjamin.
I could chime in with something if you want a few seconds to think it through, Dr. Benjamin.
Sure.
In the 1115 waiver in New York State, what we found during COVID was where there was a complete drop off in utilization and the fee for service infrastructure basically collapsed. Those PCPs that had PCP cap were the only organizations that had a continuous flow of revenue. So New York State is toying with the idea of advanced VBP models and global capitation. So we're talking about it in New York, what that actually looks like, what the details are, whether or not I believe in it 100%, all for, webinar part 2. But, the conversation is happening in New York State. It's still, a little light on details.
Yeah, I agree with PK that the conversations are ongoing. Yes. And yes, we do engage with our primary care association here in New York. It's Chicane's, the Community Health Center Association in New York State. We attend their meetings. We have quarterly webinars. They're also very helpful. I see there's another question further down on IT solutions to VBP. They're also very helpful on that and sharing best practices as well.
Thank you. And I know that Gene Polster would also say that from the Ohio perspective, that the FQHCs in Ohio are also very much so engaged with the Ohio Association of Community Health Centers, which is the primary community health center association in Ohio. And I know that Natalie has worked very closely with OACHC and the work that they do and has holds them in her favor, as we've discussed, right, Natalie?
Definitely. And one of the things that, we really are trying to do, and I've seen several different comments and questions around this, is trying to bridge the gap between, we have the FQ Association, you have your primary care, family medicine, internal medicine, et cetera, associations. And how do we start, bringing everybody together so that we're all marching in the same direction or rowing our boats in the same direction. And I think that at least here at Buckeye, we really do try to engage with all of those partners and say, what makes the most sense? How can we move this forward? And we know that, certain areas of our state even are more successful in doing that than others. And so, when we look at, there's a huge section of Ohio that's Appalachian, area. And, even just getting somebody to a physician, it's a 45-minute, 50-mile trip. So can we help stand up telehealth in an FQHC there, to provide them with greater access, things like that. So everybody has to kind of pitch in and work together, I think, is really the sum of it.
Yep. And I think that's been the theme of the webinar today with respect to engagement. It's partnership, everyone chipping in, everyone doing their best, having their finger on the pulse and ear to the ground, and being flexible and creative with respect to how we can all grow together. And I thank you all. Unfortunately, we only have 2 minutes. I know we could talk for probably hours more. So PK, I definitely think that we need to plan for a webinar 2.0 to follow up on all the great information that you all has surfaced today. But I want to again thank you, each and every one of you, for taking the time to join us. We appreciate your perspective, we appreciate your expertise, and we appreciate your continued partnership. And just in the last minute, for you all joining, thank you for joining and being with us for this hour. Hope that you were able to take away some great information and morsels of good food for thought. With respect to this webinar, it will be available to you, will be emailed to each and every one of you. We will also be uploading it to our YouTube channel. And I believe that Adrian, we will be sharing our panelists information for those who want to reach out directly to the panelists if you have specific questions for each of our panelists.
That is correct. So stay tuned for that if you have any follow-up questions.
Okay, and with that, thank you everyone for joining us today. I hope you have a great rest of your day.
Thank you.
Thank you.
Everyone.